cardiac magnetic resonance. And what we find is that the diagnosis was that of myocarditis in only 30% of these patients with an increase in troponin levels. We have 19% of the patients with acute myocardial infarction, and we have patients that, despite an increase in troponin levels, do not have major cardiac abnormalities found at cardiac MRI. This is a series with pathology when the patients underwent autopsy. And you see that the most frequent finding from a pathological point of view in patients who died because of COVID-19 is that of diffuse macrophage infiltration, 86% of the patients. Only 14% of the patients had a lymphocytic myocarditis. Then we had patients with small vessels thrombi, which are a likely cause of the increase in troponin levels, and patients with right ventricular overload and pericarditis and thrombosis. So myocarditis is rather rare in patients with COVID-19. We have cohorts done in athletes who underwent cardiac MRI. And in general, the prevalence of myocarditis is around 1 to 3 per 1,000 patients with COVID-19. We collected with Enrico Amirati at the Niguarda Hospital in Milan, I think the largest series of patients with acute myocarditis. And my next slides regard this article, which is submitted and hopefully close to acceptance. Patients were collected from Western Europe, Finland, UK, and United States. And we used classical criteria for the diagnosis of myocarditis, either endomyocardial biopsy or cardiac MRI plus signs of acute myocardial injury, that is to say increased troponin levels, were required to have a diagnosis of acute myocarditis. So these are the main results. Actually, we came with 72 cases with possible myocarditis and 54 cases with a definite diagnosis of acute myocarditis. And you see that the prevalence of acute myocarditis ranged from 2.4 to 4.1 per 1,000 patients. Here you have all the centers that were included in this study. And again, you see that the data were very consistent across the different centers. The clinical presentation of these patients with acute myocarditis was that of a severe disease, above all acutely. Most of the patients had increased troponin level. The patients had increased troponin levels, as can be expected, and most of the patients had a impairment of ejection fraction, the ventricular ejection fraction. And but there was also this marked difference between the patients with pneumonia compared with the patients without pneumonia. And we had that the patients with pneumonia associated to acute myocarditis at older age. They had cardiogenic shock at presentation in almost 50% of the cases, compared to 30% of the cases. And they had a worse impairment of left ventricular ejection fraction. Above all, these patients, and we will see here, they had a poorer outcome. Almost all the cases who died had acute myocarditis with associated acute pneumonia. And in the other cases, the deaths occurred just in the first few days from presentation, and then no more deaths. Instead, in the cases with acute pneumonia, we came to 37.6% mortality rate at 30 days. You see then when the patients survived, then they had a recover of left ventricular ejection fraction in almost all of the cases, both in the patients with pneumonia and in most of the patients without pneumonia. So very poor clinical course in the patients with acute pneumonia, but then recover of left ventricular ejection fraction in those who survive. Here are a table with the data of our recent series with COVID-19, compared with the series, again, collected by Enrico Amirati in Lombardy without COVID-19 and previously published in Circulation. And you see that overall, the outcomes of the patients with COVID-19 was worse, with also a larger impairment in ejection fraction. Therefore, in conclusion, the prevalence of acute myocarditis has been found of 2.4 per 1,000 patients hospitalized with COVID-19 when we use strict criteria for acute myocarditis, and goes up to 4.1 in 1,000 patients, considering possible acute myocarditis cases. The main difference is between patients with or without concomitant pneumonia, and patients with pneumonia have a worse hospital course, higher need of mechanical circulatory support or death. COVID-19 is associated with acute myocarditis as a worse hospital course than that of usual acute myocarditis. So thank you for your attention.
Thank you very much, Marco, for this interesting presentation. I'm puzzled. I mean, you have lots of data, and congratulations to you and to Enrico. I guess you have the largest registry in Italy for sure. After all, you have been the most impacted region, and I really remember those days when you guys had to be full-time in the hospitals and even leave your average cardiology duties and run and check with these patients. I may start with a question. You presented differences in COVID myocarditis versus non-COVID myocarditis. One thing that comes to my attention, did you see patients with pneumonia that presented already with COVID myocarditis, or was that something that came to your attention after that? Because I remember the first data that we had were mainly patients with pneumonia, and not many people really spoke of myocarditis.
Well, of course, the case series that I presented in my last slides is a retrospective data. We called, emailed to many centers and asked if they had the cases of myocarditis. So this is a retrospective, and it's difficult to say which comes first. In general, it's concomitant. Pneumonia is as everybody knows, a frequent finding. And the fact is that, as in our first case report, if a patient just has acute myocarditis without pneumonia, the outcome is good. And even if there were a few cases which something like very close clinically to fulminant myocarditis, but if the patient survives the first days, the outcome is good. When a patient has pneumonia and myocarditis, the likely explanation is that there is an overall inflammatory reaction that is involving all the body of the patient. the outcome of acute myocarditis with COVID-19 is worse than that of acute myocarditis after vaccination. And Stefan will deal with this, but will be very important also for everybody.
Okay, I have a question. The questions referring to vaccination will be most likely answered by Stefan Heymans, but I want you, Marco, if I may, give you a quick question from Robert Bell. How were patients screened for myocarditis? Were all patients with troponin elevation screened with CMR?
Again, we cannot say from our retrospective series, but well, I would recommend that we also wrote guidelines with the HFA for COVID-19 and heart failure. I would recommend an echo, and if the echocardiogram is normal, all the patients should have troponin levels measured at least at entry and after a few days of COVID-19, when all the patients hospitalized with COVID-19. If the patient has increased troponin levels, I would recommend just echocardiography. And then if it shows an impairment of the ventricular function, makes sense to have also cardiac MRI. What it is also maybe very important is to have a cardiac MRI as a follow-up of the patient, because sometimes, above all when they are young people, athletes, agonists, having a normal cardiac MRI after 1 to 3 months after the acute episode is reassuring with respect of starting agonist activity again.
Very interesting. I may proceed with another question, Marco, for you. Is there any difference? This is Charlotte. Is there any difference in long-term outcome between COVID-19 caused myocarditis and other causes?
No. What generally also our series, all the deaths occurred in the first 40 days from the acute event. Then we had a recovery, a complete recovery of ejection, ventricular ejection fraction in 90% of the patients, and the other patients just had a mild impairment. So everything is in the first few weeks. Seems to be in the first few weeks. Of course, I think more data are needed with respect like cardiac MRI, and but I wouldn't stress the long COVID is more functional or but not myocardial structure and function in the long term. This is the...
Okay, and the final question, I think this is important if you have an answer to this. Is there more prevalence from Anna Moya? Is there more prevalence of COVID-related myocarditis in patients with cardiac problems previous to COVID infection?
I'm not aware of data. What I can say very, very safely is that patients with a history of cardiac disease, they have a much worse prognosis compared with the others. And but this goes beyond the myocarditis. It's just, I mean, ARDS, septic shock, any kind of complication, and that occur more frequently in cardiac patients.
Okay, great, Marco. Thanks so much for your talk and for your answers. I'm pretty sure there are many other things that people would like to know, but it's time for me to present my friend and long-lasting collaborator, Stefan Heymans. He's based in Maastricht, and he's head of the cardiomyopathies program there. Please, Stefan, your research focuses on molecular mechanisms of heart failure, looking at the interplay between inflammatory cells, fibroblasts, and cardiomyocytes. Hence, it's very important to hear your point of view in this hard COVID topic. Please, Stefan.
Yes, thank you very much for the invitation and the very kind introduction, Gabriele. Thank you, Dana. thank you all for being here. It's, of course, a very timely topic, and also at the outpatient clinics, we are all getting a lot of questions about this vaccination-related myocarditis. Is it really causal, or is vaccination just a trigger of myocarditis? So these are my declaration of interest. So yeah, to talk about common myocarditis. So the question is always, how can a common virus, common virus, cause hyperinflammation in the heart? So I would like to draft the parallel with the annoying fever buttons, which are caused by herpes simplex virus, where always the same persons get these annoying fever buttons, depending on a certain immunogenetic susceptibility, but also where hormonal factors, additional viruses, and diseases leading to immune dysregulation may make you susceptible to get hyperinflammation in response to this herpes simplex virus. And the same is true in common myocarditis, common viral myocarditis, where also a viral infection of the heart, also common cough viruses, herpes viruses, parvovirus, enteroviruses, may lead, in an unhappy few, may lead to hyperinflammation in the heart. Also depending on immunogenetic susceptibility, HLA, and other immune genetic factors. The recent literature also points towards monogenetic mutations, mainly those related to arrhythmogenic cardiomyopathy, that also most probably through autoimmune factors or dysregulation of T cells may also lead to myocarditis, but where also environmental factors such as age, sex, gender, additional viruses, but also maybe vaccination may help and may lead to this myocarditis. So maybe the same concepts might be true in vaccination-related myocarditis, where especially the messenger RNA vaccination, of which we know that it's creating a stronger immune response than the other vaccinations, also maybe depending on an immunogenetic susceptibility, depending on sex, depending on additional viruses, may lead to myocarditis. And indeed, as I will show you, there are some similarities between common viral myocarditis and the vaccination-related myocarditis. So what about the presentation of COVID-19 vaccination-related myocarditis? So as in a common viral myocarditis, where it happens after a viral infection leading to abdominal or to a common cough, it also happens within 7 to 14 days, mainly after the second vaccination. And the numbers after the third vaccinations are somewhat less as compared to the second vaccination. It's mostly in these messenger RNA technology vaccines, more in Moderna than in Pfizer. It's mainly affecting young males, which is also the case in common viral myocarditis. But importantly, overall, if we look at all publications, there is a full functional recovery happening in more than 90% of the patients having myocarditis after the vaccines. And the survival is up to 100%. So this is a kind of overview of the risk and benefit of vaccination. So if we look at COVID-19 related injury, as we have heard from Professor Marco Metra, it's not always easy to distinguish injury with myocarditis. But of course, the incidence is quite high in hospitalized patients. So with also a high mortality, where mechanisms might be are related to endothelial injury leading to microthrombosis, also are related to sepsis and shock, to age and comorbidity. So many old men and women are susceptible to cardiac injury related to COVID-19 infection. Whereas in common viral myocarditis, as well as in the vaccine-related myocarditis, the incidence of myocarditis per se is much lower. So it's 1 to 10 in common. Both, especially in the vaccine-related myocarditis, the survival is very good. It's mainly mild presentation, whereas in common viral myocarditis, 1 to 5% may die after the acute episode. And the mechanisms are, of course, different. In common viral myocarditis, it's direct cardiomyocyte injury. There might be immunogenetic susceptibility, immune cross-reactivity, and hormonal factors may play a role. Whereas in the vaccine-related myocarditis, other factors may contribute. So there is something like the mRNA-induced immune reactivity. Also, cross-reactive antibodies may play a role, where antibodies being developed against these SARS-CoV-2 spike glycoproteins may also act against contractile proteins of the cardiomyocyte. But also hormonal differences may be involved. And that's mainly because we see that this vaccine-related myocarditis mainly happens in young males. So I will focus on 2 studies. It's difficult to present all these studies because there are many of those. But this is one study in where myocarditis has been studied after the Pfizer vaccination against COVID-19. It's a retrospective study. So 9.2 million persons had been vaccinated, and they could disclose 136 cases of myocarditis, so 1.45 per 100,000. It's mostly very mild presentation, so with probably more than 90% that completely recover at short term and probably also at long term. Fatality mortality is very low, so 1 case has been described. And so the hazard ratio is 1.7 times higher after the second vaccination. That's also a common finding, that after the second vaccination, the incidence of new onset myocarditis is much higher. So here as a control, they use historical data. And as such, they describe a hazard ratio of 5.3. But of course, that's debatable because they present an incidence of 0.3 on 100,000, whereas literature varies between 1 and 10 on 100,000 per 100,000. In another study of last year, myocarditis has been studied in Scandinavian population-based study of unvaccinated versus vaccinated people. Again, in the Pfizer, similar to the previous study, it's 1.4 per 100,000. In the Moderna, as in other studies, it's higher. It's 4.2 per 100,000 vaccinated people. The control here are unvaccinated persons. But again, the mortality is much lower in vaccination-related myocarditis as compared to non-vaccinated or common myocarditis. That's what I would like to focus on. So indeed, that cardiac arrest and death in the vaccinated, Pfizer, Moderna vaccinated people is 2 to 4 times lower as compared to the vaccinated people or the unvaccinated people. So the mortality of myocarditis is 2 to 4 times higher in unvaccinated, in common myocarditis compared to vaccination-related myocarditis. Again, confirming that the myocarditis along vaccination has a mild presentation with mostly full functional recovery and very low or absent mortality. So as such, I would like to be the devil's advocate, that these reports on myocarditis following vaccination might be just an immune reaction triggered by the vaccination in immunogenetic susceptible persons that otherwise would also maybe develop myocarditis, or maybe an additional virus has been involved in those people. But also the very proactive medical surveillance following also the large public awareness might also result in higher reporting, explaining the 1 to 5 times increase in incidence. And also, it's much better to have a vaccination-related myocarditis than the unvaccinated myocarditis, which has a much higher mortality. So again, yes, this messenger RNA related to vaccination, of course, there are most probably some direct causal link, but in view of its very low incidence, also immunogenetic susceptibility, maybe monogenetic susceptibility, and additional environmental factors such as additional viral infection, hormonal factors, and additional diseases might be involved in this myocarditis in young male following the mRNA vaccination. So in conclusion, so there is indeed a 1 to 5 times reported increase in myocarditis in messenger RNA vaccines as compared to the non-vaccinated people, mainly Moderna compared to more than in Pfizer. It's 1 to 10 cases per 100,000, mainly in young male between the age of 18 to 30. Functional recovery is very high, so the presentation is mostly mild, and mortality is nearly absent and many times lower than in common myocarditis, of course, many times lower than in COVID-19 related myocardial injury. It's still unclear whether it's really causal or just a trigger in already immunogenetic susceptible persons. And of course, the increased awareness, media attention might have resulted in a much higher diagnosis as you would expect in common myocarditis. But more and most importantly, the benefit of a vaccination strongly overweight the high risk of COVID-19 related myocardial injury and to some extent myocarditis. Thank you.
Thank you very much, Stefan, for a wonderful and very brief overview of post-vaccine myocarditis. Wonderful talk. I think there is one raised hand, and I'm going to ask Marco to ask his question. I believe you have a question, is that right? You're muted at the moment.
Yeah, sorry, but it's a very frequent question. If a patient had myocarditis, of course, there are many different degrees after the second dose of the vaccine. I mean, a question I'm having frequently is whether to have the third dose. How do you behave?
Yes, was also a question in the audience, and I just quickly checked on Google in literature, and the numbers are as such in recent surveillance that the number or the incidence of new onset myocarditis after the third vaccination is somewhat less than after the second vaccination. But the question whether if a person has myocarditis, of course, after the second vaccination, whether he or she should avoid the third vaccination, I don't think so that there are already data to give a clear response to that question.
Thank you very much, Stefan. Can I ask you, please? I'm a believer in old-style medicine. Do we have any evidence on histology on post-vaccination myocarditis?
Any biopsy studies? Yes. Well, I've seen
it's less likely, of course, because these cases are milder, much milder. But I was wondering if this data exists because through inference with the post-actual COVID myocarditis, we might actually draw some conclusions on the pathophysiology.
Case reports of a few patients that died where, of course, the direct link is questionable because most of the COVID vaccination myocarditis happens within the first 7 days. And then you see these case reports 30 days or later after the vaccination. And then they get autopsy, and then, of course, they get a classical image of T-cell related myocarditis, not so different to the common viral myocarditis. So the mechanism, I think, is it's mostly what I've seen, a T-cell response, not so different from the common viral myocarditis.
So as expected. Can I ask you also, you've discussed about this, but perhaps you would like to elaborate. Why are young males more susceptible to this?
Yes, we see the same in common viral myocarditis. So those are probably hormonal differences. So that might be involved. That's of course the most easy explanation. But of course also the immune system is probably more reactive, hyperreactive in young persons. It's well known that the immune response can be stronger, which has benefit as well, but which is detrimental when you are the one unhappy person getting this myocarditis, so that the immune response is stronger in young people. So I would say younger, stronger immune response, and of course hormonal differences, because more male than female.
Excellent, thank you very much. And there are some other questions that are coming from the audience with regards to treatment. So would you be able to elaborate very quickly on the treatment of post-vaccine myocarditis? And one particular question relates to the use of colchicine in this.
Yeah, thank you for that excellent question. I think it should be approached as common myocarditis. So it's just if there is cardiac dysfunction, you would have to give classical heart failure standard of care treatment. I wouldn't give any corticosteroids or even colchicine, because there is no evidence, even in common myocarditis, that colchicine really helps to facilitate recovery. So it's mostly the common guidelines, heart failure supportive treatment, but most of them will rapidly functionally recover. So you won't need long-term treatment.
Okay, thank you very much. Thank you very much for your answers. Fortunately, we do not have time for any other questions, but it is my pleasure to introduce the next speaker, the third speaker of the series. That is somebody who doesn't need any introduction, but I will attempt it. That is Professor Valentin Fuster. He is physician-in-chief of the Mount Sinai Medical Hospital and director at Mount Sinai Heart, Zina and Michael Wiener Cardiovascular Institute, and the Henry Kravis Center for Cardiovascular Health. He also holds the Richard Gorlin Heart Research Foundation Professorship at the Icahn School of Medicine in Mount Sinai, and is the General Director of the Spanish Center for National Center for Cardiovascular Research in Madrid, in Spain. Dr. Fuster has received the highest awards for research. He has published on many new original scientific concepts that have subsequently translated in daily clinical cardiology practice, helping patients as well as mentoring young scientists. His work has been recognized by numerous honorary degrees, prizes, awards, and by royalty. He is current editor-in-chief of the Journal of the American Journal of Cardiology, and it is my pleasure to introduce his talk, Myocardial Prevention and Treatment of the COVID-19 myocarditis.
Thank you very much for this introduction, and it's a pleasure actually to be feeling European in New York and having this discussion with you. My topic is COVID-19 cardiovascular manifestations, focusing on the myocardial manifestations. They're asking me about prevention or treatment. I'm going to emphasize few points made already by Professor Metre and Professor Heymans. And let me begin by showing that the virus enters into the body, and here's the first problem when we deal with the heart, and it's the question of myocardial injury. This is our data in New York of 3,000 patients, and which will measure troponins. And here we have the mortality is related to the level of troponins here in the bottom, compared with troponin levels on the top that are normal. 36% of the patients hospitalized of these 3,000 in Mount Sinai, New York, had troponin positive manifestations of the disease. Now, obviously, it's age dependent. This is not our work, but certainly from the healthcare database. And you see that when we talk about mortality related to troponins, certainly age plays a very important role. We look at echocardiography in all of these individuals. Certainly, I'm going to focus on the best data that we obtained in 190 of them. And what we have is abnormal ventricular function, actually in about 40% of people, left ventricular wall motion in 23%, and in the bottom is diffuse ventricular dysfunction. Then you can have pericarditis, right ventricular dysfunction, and so forth. So echocardiographic abnormalities overall in 60% of the patients. And obviously, we are talking about injury here. I wouldn't call even myocarditis. We have more to say about this in a moment. And here's the question about putting together our data on troponins and echocardiography. And basically, the mortality was very low, 3%, in those who didn't have either of those. And then here on the top is when you have high troponins and ventricular dysfunction, 34% mortality. And here is when troponins are elevated in the middle, but ventricular function is normal. So an important role of troponins by themselves. Now, when we talk about MRI, be sure that we distinguish two different things here. One is to look at myocardial dysfunction as we did with echocardiography. We see this with injury. The other is to talk about structural myocarditis, in which, there are different guidelines, but basically it appears to start with vasodilation, and then it goes into edema, and finally into the delay enhancement, gadolinium enhancement of fibrosis. If you have 2 or 3 of those, one can say most likely we have myocarditis, but certainly the most important thing is to have a biopsy. But here, myocardial dysfunction is critical when we talk about injury only. And now the question is, what happened with these abnormal values? Well, we have, for example, in troponins, here from the group of Frankfurt, they found that the highest levels of troponins continue to be high afterwards, after the patient is discharged from the hospital. And what about echocardiography and magnetic resonance imaging? Well, what is interesting, as you can see, is the function of the magnetic resonance image myocardial function. The reduce on the longitudinal, systolic function is significantly affected after discharge from the hospital, 3 to 6 months after, in 30% of people. And so diastolic function is also affected in patients, echocardiographically speaking, after discharge. So this is an issue. And actually, with MRI, you can see some structural abnormalities after the discharge from the hospital. Some of these patients may have had myocarditis, but this group, by and large, ventricular dysfunction means myocardial injury, not necessarily myocarditis, which we will be talking in a moment. So here now we have into the issue that what I presented to you, which is more of myocardial injury, these unclear therapeutic implications into what we say. So there is little I can say except the usual treatment that we have for patients who are hospitalized for COVID-19. This leads to a topic, which is now we talk about myocarditis. Well, let me first define it. And I think this is a broad review, and then by the group of Birmani that we published in JACC very recently. Myocarditis is defined, obviously, by histological evidence, myocardial damage and leukocyte infiltrate. CMR findings may be considered. I already mentioned the issue of vasodilation, myocardial edema, or fibrosis. 2 or 3 of them being present can be considered as part of myocarditis, non-invasive approach. And to confirm the diagnosis that the virus directly affects the myocardium, you need a positive viral PCR. And with all of this in mind, putting all things together in this particular study or paper, myocarditis only occur in about 4.5%, and we say of highly selected groups of individuals that actually undergoing autopsy or myocardial biopsy. Virus in COVID-19 was detected very rarely. So what we are talking about is perhaps myocarditis in a small group of individuals, but is cytokine storm-related effects, probably more important than the effect of the virus directly into the myocardium. And this is a summary of what I just presented. 4.5% of patients with myocarditis entering into the hospital. And actually, these myocarditis, typically, you can see damage of the myocardial cells, and these groups of cells with a predominance of T cells. When in injury, actually, the predominance is just macrophages. And here the question is, was the virus present? Well, in most of the studies, there is no virus that is affecting the myocardium. So it seems to me, as I mentioned, a chemical reaction to the macrophage cytokine release. Well, now here we have, if we don't have biopsy, how we can make the appropriate diagnosis? Well, there is one possibility here, and this is what was presented recently, we published with the work led by Dr. Pilar Martin in our group in Madrid, where we now detected certainly a microRNA that is just released by the lymphocytes that I mentioned, specifically the Th17 cells. And this now can give the diagnosis of myocarditis as we found in the mouse model and also in humans. Now the question is how this is going to work for the diagnosis non-invasively in patients with COVID-19. And this is research that is going on at the present time. Now, but clinically speaking, what patients are in trouble? Well, probably those who get into heart failure. And this is actually the study that we also published from Mount Sinai, that in fact, patients with heart failure with COVID-19 were about 7 or 8 to 8%, but only 0.6% the heart failure was new. In others, the patients already have manifestations previously of heart failure. So it's a very small group of patients. And here is about recently published is that from these 38 patients who actually had myocarditis, and most of them well proven, actually in about 14 of the 38, the patients had significant heart failure and they were treated with heart failure medication and also all treated with affecting the immune or treating the immune regulation with corticosteroids. From these actually 14 patients, actually 5 died. And this is the group with myocarditis that probably is more severe. I don't have much time now to talk about arrhythmias, but just to point out that in our studies at Mount Sinai, we found atrial fibrillation actually in about 6% of was new atrial fibrillation, in which the mortality was higher in this group of individuals than without atrial fibrillation. So atrial fibrillation probably, when it is new, may be a manifestation of myocarditis. And here is actually ventricular tachycardia in about 9% of patients, and significant BPCs. Also maybe such manifestation of rhythm may be related to myocarditis. So here we have an issue now, and that is that, let me go here. And the question is, what kind of medications can we give to prevent all of these? Well, here we have our step-by-step approach that we found at Mount Sinai as the virus enters, macrophage infiltration or reactivity and thrombotic phenomena. Let's start with the vaccines. And this is a large study from England, and I paraphrase what Dr. Heymans presented a few minutes ago, and that is they measure the type of vaccination, adenovirus and messenger RNA. And what they found is that in the group of RNA-based, myocarditis events predominated in the first 28 days after the second dose. People were younger than 40 years, but only 0.01% were admitted to hospital with or died from myocarditis. So this, in a way, is a matter of not excluding young people because of such information for being vaccinated. Well, this is actually leads to the issue of the anticoagulation, which is another aspect we are very, very involved. And I want to present the following information. We did a retrospective study of actually 6,000 patients at Mount Sinai. And retrospectively, we found that heparin, therapeutic or prophylactic, or apixaban decreased the incidence of mortality or of mechanical support. And this led to a prospective study. In this prospective study that I am presenting right now, this is prophylactic enoxaparin, therapeutic enoxaparin, therapeutic apixaban, and this is in patients who are hospitalized with COVID, with the endpoints being all-cause mortality, intubation requiring mechanical ventilation, and systemic thromboembolism. Well, here is an international study with 100 institutions participating, and I have to say the good news of this study is that our endpoint is going to be 3,600 patients. We already have more than 3,300, and with the DSMB just encouraging us a week ago to finish the study. I think this is going to be certainly the study that will provide information about anticoagulation with one of the three approaches that I mentioned. And the final comment I want to make, and is interesting, is the study performed also in Madrid, my colleague Borja Ibanez, and is about the inflammatory process of COVID. Well, what basically was done is the use of beta blockers. These were patients that came with ARDS, significant pulmonary problem, and we used metoprolol based on the studies of metoprolol in inflammation that we found in myocardial reperfusion. In this pilot trial of 20 patients, IV metoprolol, 15 milligrams daily for 3 days, were given to patients with COVID associated with ARDS and was safe and reduced, actually exacerbated the lung inflammation. It was reduced with bronchial lavage, pre and post intervention. There were the metoprolol group and the control group, and we found a significant improvement also in oxygenation. And this is the data that we just published. And here you have the control data on the cells that were identified in this lavage, and here is with metoprolol, and here is just histopathological presentation, and here is actually the oxygen. So here, I just like to summarize for you. I didn't have time to talk about microcirculation in the coronary arteries and so forth, but just to summarize that certainly the heart can be implicated, but mainly is implicated in this disease by injury. Very little myocarditis and almost none related to a direct effect of the virus into the myocardium. Treatment, I just presented to you what we have that is hot on possible treatments today, and I finish my presentation by saying thank you very much for giving me this opportunity. Thank you.
Thank you very much, Dr. Fuster, for this very insightful presentation. I think this is a real take-home message. So little myocarditis, lots of cardiovascular complication other than myocarditis. There is a question, I guess, coming from the Netherlands or Belgium, Paul Kreinen. Troponin evaluation is a common finding in COVID patients. However, autopsy studies of deceased COVID patients show very limited cardiomyocyte death. Does it mean that troponins are actually leaking from viable cardiomyocytes, or there is any other source?
This is very well known, actually. In fact, we have a lot of information on this. The troponin can be released actually from myocardium that histopathologically doesn't show degeneration of the myocardial cells. It's a particularly high sensitive troponin, is very sensitive to such deregulation of the myocardial cell, but not necessarily is seen structurally or under the microscope.
Very well. Another interesting question, I guess, comes from Brazil or Portugal. Beatriz Saldanha Santos. Should we screen athletes after COVID-19 infection for myocarditis before starting training?
excuse me, the question, I couldn't get the question, sorry.
Should we screen athletes after COVID-19 infection for myocarditis before starting training?
Well, I think I would screen with an echocardiogram. My colleagues already mentioned this before, and that's all what I would do, frankly. I think that you have to be screened that you are negative, so this is common sense. But in terms of being sure that the structure of the cardiovascular system is okay, to me, echocardiography is sufficient.
There was another question related to the strains of COVID. Is there any evidence that Delta gives a different myocarditis or damage than Omicron or other strains, for instance?
I don't think we have any data about this. Maybe my colleagues, Professor Metra or Professor Heymans, I certainly don't know of any data available.
Well, of course, what we see in daily life on the intensive care unit is that even with Omicron, that the unvaccinated people are much more hospitalized and have many more problems than the vaccinated ones. So I think that the Omicron continues to give myocardial injury, probably at a lesser extent than the Delta, but still vaccination is crucial.
The personal experience in this case, I don't have data specific, but yes, I fully agree. If patients are not vaccinated, I mean, the problems, including severe myocarditis, are patients who are not vaccinated. Yeah. And also with Omicron and Delta variants.
Okay, question from my co-chair, Dana Dawson.
Hi, I was just wondering, so a clinical feature of COVID disease generally, myocarditis involved or not, is lymphopenia. And we know the role of T cells and the adaptive immunity generally in any myocarditis. Do we know anything about COVID being different in eliciting responses from the adaptive immune system in this particular infection comparatively with any other viral infections? Because certainly what we have seen is of different proportions of any other myocarditic disease that we've encountered in cardiology in our lifetimes.
Well, one thing I can say to you is that when you look at the myocarditis in general, not with COVID, lymphopenia is one of the features. So, and with COVID is actually one of the features. So I cannot tell you now or to answer your question whether there are different triggers or not, but certainly the immune reaction that takes place with any type of myocarditis certainly leads towards lymphopenia as one of the aspects. I don't know the differences between both.
Okay, I think if there is no other consideration from the other speakers, I guess time's up. And we had an extremely interesting session with three extremely renowned speakers, Marco Metra, Stefan Heymans, and Valentin Fuster. So I really thank you for being here with me and Dana Dawson, and I thank the 240 people and more that attended this successful meeting. I think it was a nice success for us, for our working group, for the ESC, and for the important topic that we are having. And final remarks to Dana Dawson.
Nothing more to say, just to thank everyone and to thank the ESC staff for organizing this, for making it possible. It was our first seminar of this kind, so I think we obviously will be very encouraged to promote others. I think this has been a fantastic success, and I'd like to thank everyone again.
Thank
you.
See
you soon in person then.
Bye-bye. Thank you.
Okay.
Thank you, everyone. Thank you for being here.
Bye.
Thanks.
Bye-bye.
Bye.